It's Dr. Debbie Morris, and today we're going to be starting the next section of our physiology course by talking about the physiology of the lungs and of respiration and ventilation, so pulmonary physiology. As I have often said in this course, this segment is going to tie in very clearly with other segments of the course. For instance, when we were talking about cardiovascular physiology, we had to talk about how the right side of the heart supplies the pulmonary vasculature under low pressures, and that's where oxygen is picked up. So we'll talk about that in a lot more detail. After we talk about pulmonary physiology, and we'll have a couple of lectures and maybe a little bit of clinical correlation, we'll move on to the kidneys. And while it may not seem intuitive that there are tight connections between the kidneys and the pulmonary system, we've already touched on one, which also ties into the cardiovascular system, which is the renin-angiotensin-aldosterone system of hormones that help to control volume. But there are others that are extremely important in homeostasis in terms of how these two organs, the lungs and the kidneys, help to maintain our pH, our hydrogen ion concentration, within a very, very tight range. So let's move on and talk today about the anatomy and the function of the lungs, a little bit about concepts in physiology that we call ventilation and perfusion, about the volumes of gas in the lungs and how they are important in a clinical test called pulmonary function testing, and then talk about how gases are transported in the circulation, specifically oxygen and carbon dioxide, which are both exchanged out of the pulmonary into and out of the pulmonary vasculature in the lungs. And here we have a picture of the heart and lungs showing the great vessels, showing the trachea and the main bronchus, which are going to be bringing air into the lungs. And then, of course, the pulmonary artery, which is carrying deoxygenated blood from the heart into the lungs. So, while it is clear that the primary function of the lungs is gas exchange, there are some other functions. The lungs function as a filter to some degree, both of gases and of blood as it is going through that capillary bed, and also is a smaller than the venous capacitance but smaller reservoir of blood that can be mobilized at need when we need to start moving more blood through our heart. We divide the respiratory system, the air containing portion of the respiratory system, into two zones. And the first of those zones is called the conduction zone because it is the part of the air containing respiratory system that allows for the movement of air into and out of the lungs. It conducts air. And it consists of the nose and the pharynx, both the part of the pharynx behind the nose, which is called the nasopharynx, and behind the mouth, which is called the oropharynx, the trachea, the left and the right main bronchi, and here we're coming in, this is the trachea, and the left and the right main bronchi, and then The bronchi divide into smaller and smaller tubes down to the tiny bronchi called bronchioles, which continue to divide. But the first order of bronchioles are part of the conduction zone of the respiratory system. All of these have smooth muscle, the bronchi particularly, and down to the bronchioles, and that smooth muscle is innervated by the autonomic nervous system. There are both sympathetic and parasympathetic receptors. The sympathetic receptors are adrenergic receptors, they're obviously adrenergic receptors, but they're beta 2 receptors. And when triggered by epinephrine or by norepinephrine, they dilate, or by drugs that are adrenergic agonists, like albuterol, which is a beta 2 adrenergic agonist, so dilation. And then the parasympathetic receptors are muscarinic and cause constriction. Beyond the conduction zone, where we begin to have alveoli or air sacs that allow gas exchange, we call that the respiratory zone. So there are some alveoli bulging off of the respiratory bronchioles, past the first order of bronchioles that are just tubes. And then there are ducts that contain more alveoli, and then all of the terminal alveolar sacs. So the respiratory zone consists of respiratory bronchioles, alveolar ducts, and alveolar sacs. And the theme here is alveoli. Here we have a cast, or actually I think this is probably a computerized image, 3D image, showing the conduction zone. And here we have a cast showing the conduction zone, and probably down to the beginning of the respiratory zone. In the respiratory zone, we have alveoli, and alveoli are amazing little structures. They're tiny air sacs with a single wall that consists of a couple of very subtle layers. There is a capillary, and if you remember, capillaries are lined by a tissue called endothelium and surrounded by a non-cellular structure called the basement membrane. In the alveoli are lined by an epithelium, so a flattened lining tissue that is a single layer. So we have epithelium, basement membrane, capillary, basement membrane, epithelium. And we can see how the red cells within the capillary are in very near contact with the air in the alveoli, even though they're contained within the capillaries. So here we have an electron micrograph. This is actually a very high magnification traditional micrograph. Here, this is an electron micrograph that is showing the cross section of a capillary. The capillary is surrounded by basement membrane here called extracellular matrix. By the endothelium always, and endothelial cells have nuclei. So the capillary consists of the endothelium, the extracellular matrix or basement membrane, and then immediately is the epithelium, and this is the nucleus of an epithelial cell. So we have the lumen of the capillary, the endothelium, the basement membrane or extracellular matrix, and the end epithelial cell, and then the lumen of the alveolus where air is. So all of this is within a very tiny space. So this is a couple of microns or micrometers, I think. 0.2 microns. So the barrier between blood and gas has to be thin to allow for gases to diffuse. The basement membrane contains collagen, which allows it to maintain its strength and elasticity. And this structure of alveoli creates an enormous surface area for this blood gas barrier, for this place in which blood comes into near contact with air, allowing for the diffusion of oxygen and carbon dioxide. So it's about 50 to 100 square meters altogether, which is huge if you spread it out. And there are about a half billion alveoli in any given individual. So this is a less high magnification micrograph showing the spongy nature of the pulmonary tissue, of the alveoli and the ducts and bronchioles that lead into the alveoli, and the capillaries and vessels that lead through the pulmonary system. So let's leave that for a minute and talk about how substances are ejected from the conduction zone of the lungs. There is something that is called mucociliary transport, or the mucociliary escalator. Within the tubes that form the conduction zone of the airways, there are cells that make mucus, and they are called goblet cells, and they make a thick layer of mucus. They are sitting amongst cells that have cilia, and those cilia extend into a liquid layer with the mucus kind of sitting on top. And those cilia are constantly sweeping fluid and mucus and anything that gets stuck in the mucus on the way down. So dust particles, viruses, anything that we inhale that is not meant to get into the ventilatory respiratory zone. And it gets pushed until it ends up in the upper airway, where we may cough it up or where we may clear it up and then swallow it typically. So there are goblet cells and ciliated cells. Within the alveoli, I mentioned the epithelial cells that line the alveoli, but there are two types. One of which, the main alveolar cells, are structural. They provide they make collagen, and they provide the structure that maintains the wall of the alveolus. But we need an additional kind of cell, which is called a type 2 cell, that produces a substance called surfactant to reduce surface tension. So there are type 1 cells that are structural and type 2 cells that are globular in shape. They have little villi, but they make surfactant, and the reduced surface tension of the fluid within the alveoli allows the alveoli to stay blown up. If there's high surface tension, alveoli would collapse as the forces of the surface tension of the fluid would draw that fluid together. There is a third type of cell in the alveoli, and that is macrophages, which are part of the immune system, and that are phagocytic cells that can move about, and they clean up foreign particles that have made it down to the alveoli, and a group of alveoli is called an acinus. So a few foreign particles can make it down into the respiratory zone. There are no cilia there, so the mucociliary escalator only functions in the conduction zone, not in the respiratory zone. So in the respiratory zone, anything that has made it that far has to be cleaned up by macrophages. The macrophages then are able to migrate into the bronchioles where the mucociliary escalator is functioning, and from there they are carried up to the larger airways by the cilia on the mucus layer. So let's talk a little bit about where air is in the lungs. You know, we've talked about these two zones, the conduction zone and the respiratory zone. The conduction zone is considerably smaller. It's got another name, which is the anatomic dead space. And that's basically because air is moving through it, but it is not doing anything else. So it's the anatomic dead space or the conduction zone, and it contains about 150 mLs of air at any given moment. Each terminal bronchiole supplies a bundle of alveoli that is called an acinus. So one terminal bronchiole, one acinus, but a bunch of alveoli. And if you add up the volume contained within all of those acini, all of those alveoli, there's about 3 liters of gas there. So about 150 ml in the conduction zone, about 3 liters in the alveoli, in the acini. As the gas in the alveoli has to interact with the blood in the capillaries, there are some patterns by which those vessels are distributed. The pulmonary arteries follow the airways and branch and branch and branch. The veins diverge at the smaller airways where they will pick up the in venules, the discharge from the capillaries from the division of the arteries. Remember that the blood pressures in the pulmonary vasculature are much lower than in the systemic vasculature, so the vessels don't have the thick muscular walls. They're thinner, the walls of the vessels, than systemic arteries. And they have a function that is, well, actually, they are attached to the airways, and the airways and vessels provide some support to each other, and the airways help to hold those small vessels open. And then finally, just as those walls are smoother, there's less smooth muscle in them than there is in the systemic system because of lower pressures. Where the veins begin, the venules, there is a little bit of interstitial space here called perivascular space that is where edema can begin to accumulate. When pressures in those veins are high, some fluid can leak out of the veins into this perivascular space. There is an additional circulation to the pulmonary system that is the bronchial arteries. So you know that the pulmonary artery carries 100% of the blood, same as cardiac output. So say 5 liters a minute at rest from the right heart into the pulmonary system and then back into the left heart. But there are arteries that are branches off of the aorta and the intercostal arteries that supply the larger airways and the bronchi. And that is sort of it functions as a second circulation, and it is carrying not deoxygenated blood, but oxygenated blood to make sure that the airways that are not in contact with the alveoli are getting adequate oxygen to their cells. Now, let's get back to these ideas of the conduction zone and the respiratory zone. Here we have a little infographic showing the conduction zone, which is the trachea, the main bronchi, and then the branching bronchi down to the first order of bronchioles. Okay. And then we have our respiratory zone, where we have bronchioles that start to have little alveolar sacs bulging off of them, the respiratory bronchioles, into the alveolar ducts. The terminal bronchioles supply an acinus, and there are multiple alveoli and alveolar sacs. So the conduction zone, 150 ml, is the dead zone. Nothing is happening in terms of gas exchange here. And the circulation to here is primarily from those bronchial arteries. Once we get to the transitional and respiratory zones, we are getting gas diffusion across that blood-gas barrier. The blood flow into this area is from the pulmonary arteries, so it's deoxygenated blood exchanging gases, losing carbon dioxide, picking up oxygen. And so this is where gas exchange occurs. And this is where blood gases, basically, as I said, are exchanged and transported. It is extremely important, and we will talk a little bit more about this, but extremely important, particularly clinically, that ventilation, the amount of air making it to this respiratory zone, is closely matched to blood flow, to circulation, to that value that we called Q or F, flow, but tends to be called Q when we're talking about respiratory physiology. So there has to be a match between ventilation and blood flow. And then finally, an extremely important role of ventilation is the maintenance of an appropriate amount of carbon dioxide, because carbon dioxide has extremely important effects on the balance in our fluid of hydrogen ions, on acid-base balance. And so CO2 is important there, both in its function as a gas which can dissociate, which can, when dissolved in water, dissociate into a hydrogen ion and bicarb or HCO2, okay, HCO3, I apologize. Um, so the bicarb and the gas are both important in acid-base balance. We'll talk a lot more about that in a couple of weeks. Now, as we go through that conduction zone, from the trachea to the main stem bronchi to the divisions of bronchi, the cross-sectional area of the airways doesn't change much until you get to those terminal airways, the respiratory bronchioles. But as you get to those smaller airways, while the volume of gas moving through them is the same, the cross section becomes increasingly great, which means that the forward velocity of the gas movement becomes much smaller. And that's important because in the respiratory zone, you need time for gas molecules to diffuse across that blood gas barrier. And finally, by and large, pollutants don't get that far. So they don't get to the peripheral alveoli. They can't get past this point at which gas movement slows down tremendously because of the vast increase in the cross section of the airways. So we have reached the time where we're going to talk about breathing or ventilation. Every breath we take is about 500 milliliters. That breath, as we take it in, about 150 ml, stays in the anatomic dead space, right? Because while air is moving, that air doesn't have any contact with alveoli. The other 350 ml makes it into the respiratory zone, or the area where gas is exchanged. As continuously blood is flowing from the pulmonary arteries into the pulmonary capillaries, the volume of blood in the capillaries is only about 70 ml. So there's a little bit of blood and a whole lot of gas in the alveoli. We need a larger volume of gas because the diffusion time of gases in the gas phase is faster than the diffusion rate in the liquid phase. So you need a lot of gas in order to get adequate gas exchange into that smaller volume of liquid in contact with the gas. So remember that the gas in the alveoli is about 3 liters. Tidal volume is about half a liter. The anatomic dead space, that conduction zone, the throat and nose and trachea and bronchi down to the first order bronchioles is about 150 ml. And then this 3 liters of alveolar gas is in contact with a small amount, 70 mLs of blood in the pulmonary capillaries. Now, we talked about a formula for cardiac output, which was the amount of blood in a single systolic ejection, the stroke volume, times the heart rate, the number of times the heart beats in a minute, and you get about 5 liters a minute. There's a similar formula for ventilation. So if the tidal volume is about 500 mLs and the respiratory rate is about 15 per minute, we have a total ventilation of about 7,500, 7.5 liters a minute, 7,500 mLs. In each breath, some of that air remains in the dead space in the conduction zone. So of the tidal volume of 500 mLs, only about 350 mLs is making it to the respiratory zone. And so 15 times 350 is about 5,250 mL. So about 5 liters of gas a minute is making it to the alveoli. And the entire cardiac output, which is about 5 liters of blood, goes through those capillaries, obviously in small amounts. At any moment, there's only 70 mLs in the capillary, but over the course of a minute, 5 liters of blood have passed through the pulmonary circulation. And so this is, earlier I said you needed matching of ventilation to circulation. And here we can see that there's a ratio of ventilation to perfusion or flow to Q, circulation. And that ratio actually ends up being about 1, because about 5 liters of blood flow through the pulmonary vasculature a minute, and just a little more than 5 liters of air makes it into the respiratory zone. And so we have this thing called the VQ ratio, or the ventilation perfusion ratio, which is a match between ventilation and perfusion under normal conditions, very close to 1. Now, one of the ways in which we use a lot of this physiology information in clinical medicine is when people are having issues with their breathing. We do tests that we call pulmonary function tests, and spirometry, which is the measurement of breathing, of volume and flow of breaths. And they're called PFTs. So this slide gives you a couple of important definitions, and we'll talk about some more as we go through. But the tidal volume is the amount of gas that moves in a single breath. Okay, that's tidal volume, and we've already said that that's about half a liter, about 500 mLs. The amount of gas that is in the lungs when you breathe in as far as you can breathe in is the total lung capacity. When you breathe out all the way, there's still some gas left in there, right? There's the gas in the dead zone, but there's still some gas left in the alveoli, because otherwise they'd collapse. And that amount of gas that's left when you breathe out all the way is called the residual volume. That's like breathing in all the way until you can't breathe anymore. That's total lung capacity. Breathing out all the way until you can't breathe out anymore. What's left is residual volume. But there's something else, which is what's left in the lung at the end of expiration during a normal breath, because you don't push as much air out normally during every breath as you would if you were doing pulmonary function test. And that is functional residual capacity. So residual volume is what's left if you breathe out all the way. But if you're just doing normal breathing, the amount of gas left in the lungs after a normal expiration is functional residual capacity. Now, there are things you can measure. You can measure total volume. We can't easily measure residual volume. there are other techniques that can be used, but they're rarely used. They include something called helium dilution and a plasmizograph or a body box where the respirations are done inside of a box with an extremely sensitive manometer, a sealed box, so that pressures are measured and volumes are computed. So here you see a patient with lungs. His nose is clipped to make sure that the breathing that he's doing is through the device, through the mouthpiece. The measuring devices are here. There's a piece of paper, a cardboard disposable mouthpiece. Obviously, you don't want to reuse something that goes in people's mouths. And then there's a little computer with a printer often and a screen. And this is showing that tidal volume, normal breathing, 500 ml. When we have him breathe all the way in, we are getting something called the inspiratory reserve volume, which is really everything. It's the residual volume, the expiratory reserve volume, the tidal volume, and the inspiratory reserve volume. Sorry, it's not all of that. That's total lung capacity. So inspiratory reserve volume is the volume from a normal expiration to a full inspiration. Okay. Expiratory reserve volume is from a normal expiration to a full expiration. And residual volume is what's left that you can't measure, that you can't expire. And this again is just showing over time these volumes. Tidal volume, maximum inspiration, which is the inspiratory reserve volume, maximum expiration, which is the expiratory reserve volume, that bit that's left that we can't measure, that is the residual volume. Now, this is an important one. From the maximum expiration to the maximum inspiration is called vital capacity. And then everything added together is total lung capacity in the neighborhood of 6 liters of gas. So the tidal volume, that 500 ml that we breathe in and out with a normal breath, is the dead space, say 150 ml, plus the gas that makes it from that breath to the alveoli, which is about 350 ml. So with each breath, we're not exchanging all of the air in the alveoli, only about maybe an eighth of it. We subtract the dead space ventilation from the total ventilation to get alveolar ventilation. So the oxygen that is picked up by the blood in the pulmonary vasculature capillaries and then sent through the pulmonary veins into the left side of the heart is transported to the tissues, where it is released into the tissues. It diffuses into the tissues. Carbon dioxide, which is a waste product of a metabolism, is picked up in the tissues and transported by the blood back to the lungs. And how these two gases are transported is quite different. So the next few slides are going to be about that. In dry air at sea level, the concentration of oxygen in normal air is 21%. which means that of the molecules in a given volume of air, 21% are oxygen. It means that in a deciliter of air, 21 mLs are oxygen. It means that the fractional concentration of oxygen is 0.21, and that if you added up all of the fractional concentrations of all the gases in the air, mainly nitrogen and oxygen, and then a little bit of CO2 and a bunch of very tiny amounts of other gases, you'd get 1. So we need to talk about a concept called partial pressure, because when we are measuring oxygen levels in blood, we are considering the partial pressure of oxygen in blood. So if you multiply the fractional concentration of a gas by the barometric pressure, you get a measurement in millimeters of mercury, because it's a fraction of 760 millimeters of mercury, which is the barometric pressure more or less at sea level. So the partial pressure of oxygen at sea level is 0.221 times 760, which is 160 millimeters of mercury. But it's really a little bit less, because our air isn't dry air. There is water vapor, which is a gas, and the partial pressure of water vapor is 47. So if you did all the computations at body temperature, 37 degrees centimeter, the partial pressure of oxygen is about 150. And that's the computations. So the partial pressure of a gas in a liquid is in equilibrium with the partial pressure of the gas in the air. And it depends on a bunch of things. It depends on the solubility of the gas, and it depends on the oxygen carrying capacity of the liquid. In water, the amount of oxygen dissolved in water is considerably lower than the partial pressure of oxygen in the atmosphere. But we have a carrying molecule called hemoglobin to which oxygen binds, and which allows the partial pressure of oxygen in blood to be considerably higher, and allows us to carry an adequate amount of oxygen to the tissues, which simply dissolved oxygen wouldn't do. Beyond, a very small organism of a few cells, with all the organisms in contact with a dissolved oxygen in a fluid. So what is hemoglobin? Well, it's a protein, globin, linked to heme, which is an iron porphyrin. And the globin has alpha chains and beta chains. And in any molecule of hemoglobin, there are 2 alpha chains and 2 beta chains. And there are 4 heme sites, and each heme molecule, can carry an oxygen molecule. So each molecule of hemoglobin can carry 4 oxygen molecules. And here we have a nice little picture of these folded proteins that are globin: alpha chain, beta chain, alpha chain, beta chain, a heme group, an iron porphyrin that's residing within each globin chain. And then there are loads of these within a red blood cell, and an oxygen molecule can bind to each heme site. So this allows red cells to hold a ton of oxygen, but the oxygen has to get there and it has to leave. So there's something called the oxygen dissociation curve. We measure something called hemoglobin saturation, which is the percentage of the oxygen, the O2 binding sites that are occupied by oxygen. Of the oxygen that is being transported in blood, only a little bit of it is dissolved oxygen. But when we add together all of the oxygen binding sites in hemoglobin and dissolved oxygen, we have something that we will call oxygen capacity. And there is a curve with an S shape that helps us to understand how oxygen is bound to hemoglobin and how oxygen is released. As oxygen molecules attach to the heme and a hemoglobin molecule, at first it's kind of hard and then it gets easier. So this is why this curve is S-shaped. The oxygen associates and dissociates from the hemoglobin. Even when we go to high altitudes where the atmospheric oxygen is low, it may still be 0.21, but it's a far less oxygen because the density of the air is much lower. But hemoglobin has a high affinity for oxygen, so a lot of it will attach to the hemoglobin. And there are things that change the ability of oxygen to bind to or release from hemoglobin. As I said, one thing is that initially it's kind of hard for oxygen to attach at all, right? But once the first oxygen attaches, the hemoglobin has a much higher affinity for oxygen, and oxygen is going to bind easily. Once it's almost full, it gets harder to attach that last one. When the temperature is low, when the pH is high, when the partial pressure of carbon dioxide is low, and when there is a low level of a chemical called 2,3-DPG, this curve shifts to the left. And when it shifts to the left, it's a little easier for that first one to attach, right? And it holds on. It holds on tighter. It's a little harder to let go. And the opposite things, a higher temperature, a higher level partial pressure of carbon dioxide, a higher level of 2,3-DPG, or a lower pH in the blood, shifts this curve to the right, and that decreases the affinity of hemoglobin for oxygen. Okay, decreases the affinity and makes it way easier to release it. So if you think about it, in the lungs, you are releasing your carbon dioxide, the temperature is lower, and you're going to pick up oxygen. And in the tissues where the temperature is higher and carbon dioxide is being produced, you're going to release, decreased affinity. Yeah, you're going to release the oxygen. So this oxygen dissociation curve tells us about how hemoglobin is able to both attach to oxygen and release oxygen, because just carrying oxygen isn't quite enough. So remember, don't worry about the 2,3-DPG, but remember that if this curve shifts to the left, it means a higher affinity for oxygen, and that the things that shift it to the left are lower temperatures, lower concentrations of carbon dioxide, and a higher pH. And that a shift to the right means a lower affinity for O2, so it's going to release O2, higher temperatures, higher PCO2, and lower pH. In arterial blood with a partial pressure of oxygen of about 100, which is pretty normal, the hemoglobin is about 97% saturated. In venous blood, so mixed venous blood is basically the venous blood in the vena cava that is being returned to the heart. Much of the oxygen has been released and used. The PO2 of oxygen, or PO2, is about 40, and oxygen saturation is still about 75%. So in arterial blood, almost all of the hemoglobin sites are filled, and in venous blood, about 3 of the 4 are filled. So there's still quite a bit of oxygen in venous blood, which is why doing chest compressions without ventilations is still pretty effective, because we're still circulating blood where oxygen can be released in the tissues. The P50 for oxygen is at 50%. Oxygen hemoglobin saturation is considerably lower. So we can estimate oxygen saturation by measuring the partial pressure of oxygen. Now, hemoglobin has different flavors. There are different types of hemoglobin. Some of them are normal and some of them are abnormal. Hemoglobin A is what we would consider normal adult hemoglobin. The hemoglobin in a fetus has to have a higher oxygen affinity in order for oxygen to be picked up across the placental barrier and move from maternal hemoglobin to fetal hemoglobin. So the maternal hemoglobin oxygen affinity has to be lower than the fetal hemoglobin oxygen affinity, so that oxygen can diffuse, can disassociate from the maternal hemoglobin A and attach to the fetal hemoglobin F. Okay, so hemoglobin F has a higher oxygen affinity. At birth, we still have some hemoglobin F. We are already making some hemoglobin A, and over the course of early infancy, we switch from making hemoglobin F to making hemoglobin A. One of the abnormal hemoglobins, and there are a number of them, is called hemoglobin S, which is the hemoglobin that is coded for by the sickle cell anemia gene. And this is a mutation that causes the hemoglobin to have an altered shape. And this hemoglobin changes shape dramatically and crystallizes when oxygen concentrations are low. And that causes the cell to deform from its normal biconcave disc shape into sort of pokey crescents, which are much more fragile, which lodge in capillaries, causing potential blockages of blood flow and ischemia and pain. And sickle cell anemia can be a very serious disease. People who have the trait for sickle cell anemia and have a single abnormal gene. So they have a gene for hemoglobin A and a gene for hemoglobin S, and under normal circumstances, they do just fine. But if you take them to high altitudes where the oxygen concentration is considerably lower, their abnormal hemoglobin, the hemoglobin S, starts to deform and they can have sickle crisis. Um, it's unusual and you have to have unusual circumstances like very low oxygen concentrations. I have a friend who went with his wife's family to Estes Park, Colorado for a family reunion because his wife's dad used to work in the Rocky Mountain National Park and they lived in Estes Park. And no sooner did he get there than he started having abdominal pain and chest pain and shortness of breath and ended up in the emergency room and had to have supplemental oxygen for the rest of the week that they stayed in Estes Park. This is showing that oxygen dissociation curve again, but comparing adult hemoglobin, hemoglobin A, with fetal hemoglobin or hemoglobin F. And you can see that the fetal hemoglobin curve is considerably shifted to the left, meaning that fetal hemoglobin has a much higher affinity for oxygen than adult hemoglobin. At a given partial pressure of oxygen, a higher percentage of the fetal hemoglobin will be saturated, will be bound. When people are anemic, their oxygen dissociation curve, which means they have a low content of hemoglobin in their blood. So anemia shifts the oxygen dissociation curve to the right, making it even harder for the hemoglobin to carry adequate oxygen at a given PO2 level. Carbon monoxide is interesting. It has a much higher affinity for hemoglobin than oxygen does. So 24 times as high. If a hemoglobin molecule needs to choose between oxygen and carbon monoxide, it's always going to choose carbon monoxide. And unlike oxygen, once a carbon monoxide molecule binds to a hemoglobin molecule, it stays bound, which means that that hemoglobin now isn't able to pick up oxygen and cycle gases to and from the lungs. Once about a third of the hemoglobin is attached to carbon monoxide, the curve shifts to the left, making it even harder to release oxygen in the tissues because a curve to the left means it's easier for oxygen to bind or anything. So even if there's just a little bit of carbon monoxide in the atmosphere, it's going to easily bind, strongly bind, replace the sites where oxygen should be binding, and make it harder for oxygen to release. So it doesn't take a lot of carbon monoxide in the atmosphere to kill you, to be very toxic, to completely overwhelm the hemoglobin and make it impossible to carry oxygen to the tissues. Now I want to shift and talk about how carbon dioxide is transported. I said that oxygen can dissolves in water, but not very well. But carbon dioxide is very soluble in water, which is why we have soda, right? We are able to easily dissolve large quantities of carbon dioxide in water, and if we put it under pressure, even larger, and so we have fizzy water. That carbon dioxide that is produced in tissues is transported in three different ways. Okay. Some of it is dissolved, and that's just because it's so soluble. So in arterial blood, about 5% of the carbon dioxide is dissolved. In mixed venous blood, about 10% of the present carbon dioxide is dissolved. I mentioned that carbon dioxide in water can dissociate into an acid and a base. So H2CO3, which is hydrogen carbonate, it's carbonic acid, which dissociates into a hydrogen ion and a bicarbonate ion, a hydrogen cation and a bicarbonate anion. And then finally, carbon dioxide can be transported attached to hemoglobin, but not in the same way oxygen attaches to hemoglobin. It binds with the amino acids inside the red cell and becomes something called carbamino compounds. So if you add carbon dioxide to water, you make a little bit, you dissolve some of the carbon dioxide, some of it reacts with the water, forming carbonic acid, and that's normally a pretty slow reaction. But there's an enzyme, and there's a lot of it in red blood cells. There are other places we'll talk about this enzyme. That enzyme is called carbonic anhydrase, and that enzyme accelerates this reaction in the red cells, so that carbon dioxide dissolved in water diffusing into a red cell is exposed to carbonic anhydrase, which catalyzes the reaction between water and carbon dioxide, making carbonic acid, which dissociates into a hydrogen ion and a bicarb ion, HCO3. I mentioned the carbamino compounds. So sometimes the CO2 links to these terminal amine groups of the proteins in hemoglobin, and that's carbamino compounds. So we talked about dissolved CO2. We talked about bicarb, which is the result of this chemical reaction that occurs when carbon dioxide reacts with water, catalyzed by the enzyme carbonic anhydrase. And we talked about carbamino compounds. And this diagram is just illustrating all of those things. Here we have tissue in which metabolism is taking place, requiring oxygen. The oxygen is bound to hemoglobin. And in the tissues where the temperatures are higher and the CO2 is higher and the pH is a little lower, that oxygen gets released from the hemoglobin and diffuses into the tissues through the plasma, across the capillary wall. At the same time, carbon dioxide in the interstitial fluid in the tissues is diffusing into the plasma, where some of it is dissolved, and it is very soluble in lipids, so it easily diffuses across the plasma membrane of the red cell. Dissolved, some of it binds to the terminal amine groups in the hemoglobin, becoming carbamino hemoglobin, and some of it reacts with water under the influence of carbonic anhydrase to make carbonic acid, which dissociates into a hydrogen ion and a bicarb ion. And that is then the bicarb ions are carried in the tissue along with all the other ions, in the plasma, along with all the other ions in the plasma. So this is sort of how CO2 is moving through tissue, through plasma, and in the blood cells in capillaries.